Once effective treatment has begun and medications have reached therapeutic levels, it's time to start thinking about limit setting. Now, limit setting is not the same thing as discipline. You can learn more about discipline in our video, Discipline with a Mood Disorder. But the purpose of discipline is to put an end to certain behaviors and teach new ones to replace them. Limit setting, on the other hand, is about setting some guidelines to support acceptable choices, or to think of it another way, to establish some basic domestic rules, if you will, and find ways to gently enforce them. As we know, when mood disorders, bipolar disorder, or fear of harm are untreated, they all wreak havoc on the home environment. Parents have been trying to manage for a long time, and it's exhausting. For those with only one child, these challenges are all they've ever known. For those with other children, they likely realize that their parenting differs between their neurotypical children versus the one who struggles with mental illness. For parents, to hear that they now have to set limits can feel like a slap in the face, reminiscent of all the unhelpful advice they've had foisted upon them from well meaning people who might not have entirely realized that what they were actually saying was, "You're a bad parent." Hurt parents think to themselves that they have been setting limits, that their kid hasn't been ruling the roost. And in fact, when their child is stable, they're usually really very well behaved. It's true that children with mood disorders, bipolar disorder, or fear of harm don't believe they're the ones in control, and they aren't intentionally trying to be controlling. However, the accumulated effect of their symptoms on their parents, family, and household influences how everyone around them reacts. Everyone around them has been, likely for many years, reacting to them and their moods nearly constantly. And caregivers have been unwittingly basing their behaviors and actions and choices on the child and on how well or poorly they're doing. It has become necessary, in order to have even a minimum of peace, to be incredibly attentive to their mood state. So much so that it becomes, essentially, an unintentional handing over of control to the child. The best way to get started on changing this dynamic is to first remember who the parent is and that what the parent says goes. I want to pause here and make one thing very, very clear. This does not mean that the parent should be in any way authoritarian with their child. We're not talking about setting arbitrary rules that must be followed without explanation or reason, nor does it mean that the children can't be active participants in establishing the rules and guidelines for living. Children must be included, respected as individuals with valid needs whose quality of life is a priority. Additionally, authority figures need to know they are free to change their minds, admit when they're wrong or have made a mistake, compromise, or choose to provide comfort when needed. But children, especially ones with mood disorders, bipolar disorder, or fear of harm, especially, need to know that someone they trust is in charge. And when they have boundaries and limits that are set and enforced lovingly, those boundaries and limits help them to feel safe and cared for. More often than not, after years of feeling held hostage emotionally by the child's mood, parents and caregivers tend to lean towards either rigidity and an uncompromising refusal to do what they think of as giving in, or they unconsciously give the child more control than they should really have, just to keep the peace. Recognizing these potential pitfalls doesn't mean that those bad parent messages were actually true. They're not. But it still may be time to reclaim that role as parent. Once the parent or adult hat is firmly back in place, caregivers can start implementing simple rules that are easy to follow. These rules need to be introduced when the child is in a stable mood state so they can be as receptive as possible and the rules won't be perceived as a threat. Any system put in place should involve positive reinforcement, not punishment. And when the child follows the rules, they should be given that positive reinforcement immediately. Praising what they have done and that they have done what was expected is important. The use of the term expected is an important one as we look at implementing rules and limits. Children with mood disorders, and especially bipolar disorder and fear of harm, have lived their lives receiving the message that they're bad when their symptoms are active. So, this characterological assessment being either good or bad as the result of good or bad behavior can be devastating to their sense of self. This good bad dichotomy is incredibly unhelpful and has troublesome side effects. But we can eliminate it by changing the vocabulary from good behavior to expected behavior and from bad behavior to unexpected behavior. In addition to helping their self esteem, this language and framing can help the child understand more about the impact their behaviors have on those around them socially and can help bridge the gap in emotional development that often occurs as a result of mental illness. In this new paradigm, when a child does what's expected, they're given positive reinforcement to encourage this behavior to continue or to be repeated. This reinforcement can be delivered as verbal praise, which should include a specific and clear reference to the way the expected behavior is not only benefiting the child personally, but if possible, how it makes the whole environment improved. For example, if the child clears their plate from the table to the sink when asked, the response could be something like, "Thank you so much for clearing your plate. It's so nice to see you taking responsibility for your things and cleaning up after yourself. It's such a big help to all of us when we each do our part." By reinforcing these messages when the child is feeling stable and receptive, they can be called upon later when they might be resistant. When there is resistance or the child doesn't follow the guidelines, the first thing to do is always double check whether the resistance is misbehaving or active symptomology. With the fear of harm diagnosis, don't forget to check for temperature dysregulation by looking for red ears, flushed face, or removed clothing. Then, if it's clear the behavior isn't symptom driven, the foundational work of defining limits that's already been done during a calm and stable period can be drawn upon and referenced. A statement such as, "I know you can clear your plate by yourself. You're learning to take responsibility for cleaning up after yourself, and that makes you proud of yourself. Later, you may look back and wish you'd completed this chore." This reinforces the limit, encourages compliance, points to positives, and makes a connection to later intrinsic consequences. A reward can be given for compliance, such as 15 extra minutes of TV time or some other type of treat. But be careful. This strategy can backfire depending upon the degree of perfectionism the child is plagued with. Remember, fear of failure can make completing a simple task for a simple reward suddenly seem impossible and overwhelming. It's likely going to be far more effective not to tell the child of this reward ahead of time. Having the reward appear spontaneously after the task was completed or rule was complied with will eliminate the anxiety that the prospect of a potential reward can trigger. We might think that telling the child beforehand might work as motivation, but for a child with a mood disorder, bipolar disorder, or fear of harm, it will actually just feel like unbearable pressure. In keeping with this idea, when a reward is given, it's important to reinforce why it's being given. And the why is not because the expected behavior was done, but rather the reward is given and framed around the change that it represents. For example, maybe the child accepted responsibility for something or broke the cycle of acting out, were able to problem solve, or were able to take control of their emotions. or didn't allow the conflict to escalate. Summarizing for the child could go something like this: I know you didn't want to clear your plate, but you were able to explain your frustration about it instead of acting out. Let's celebrate with 15 extra minutes of device time. There's also nothing wrong with someone else doing a chore for the child or teen once in a while if they just don't have the resources left to do it for themselves. This is a simple kindness that hopefully most people would want to extend to anyone they care about. If a child with a mood disorder, bipolar disorder, or fear of harm has reached the end of their stamina, energy, or emotional gas tank, stepping in and removing the burden of the chore can be as, if not more, effective and valuable in teaching limits than forcing follow through. In these cases, it's helpful to pair the action of doing the chore for the child with a statement like, you're feeling tired and overwhelmed right now. So, to be kind, I'll clear your plate for you so you can rest. Maybe you'll be able to do the same for someone else sometime. By verbalizing all of this, clear and easy to understand expectations are still being reinforced without anything feeling punitive to the child or teen. Realistically, these strategies aren't going to work every time with every child and may not appear to be working at all at the beginning. And honestly, some adults have trouble with this strategy because it can feel a bit silly saying all of this out loud. But over time, it will sink in for the child. And by repeating this kind of reinforcement over and over again, the child realizes that there are clearly defined expectations on things they have some control over, that their efforts will be praised and appreciated, and that they will be encouraged and supported when they just can't perform. It will take time, but these strategies will slowly have an effect if implemented consistently. One important aspect of the limit setting process is reflecting on some pretty important questions. The first of which is, to what degree does the child have the ability to control themselves when not symptomatic? In the beginning, there may not be much ability at all, to be honest. As we've discussed before, kids and teens with all kinds of mood disorders have struggled their whole lives with symptoms over which they have little to no control, and they have no muscle memory to tell them how to behave when they do have control. So it's fairly normal and expected that at first they'll fall back into those old patterns of behavior. But over time, as stability becomes more familiar, and as their self confidence grows, and as they learn new ways of doing things, their ability to control themselves will grow too. We need to be careful not to expect too much too soon, but setting up a supportive scaffolding around them allows them to grow within and then beyond it, and it will help them figure out how to develop that behavioral control. The next question is, to what extent has parenting been dictated by the child's moods? As we discussed earlier, the answer is probably a lot. Parents will be inclined to minimize their own experiences of feeling beaten down, abused, and traumatized by their child's illness. But we can't dismiss the effects the illness has had on the parents, families, and caregivers. They often think that as an adult, they should be able to take it all in and do it in stride. But the truth is that parenting is shaped through interaction, which means that previous traumatic experiences driven by the child's unpredictable and involuntary mood swings have caused their own pain and consequences. But what was done in the past doesn't have to dictate what happens going forward, especially once the child or teen begins to stabilize as a result of treatment. At that point, there comes the opportunity to finally be able to be more consistent, to be less reactive, and to give the child room to experience the world and emotions without having to solve everything for them. A trickier question many parents ask is, to what extent is it reasonable to hold the child to age appropriate standards? This is tricky because kids with mood disorders, bipolar disorder, and especially fear of harm tend not to be developmentally aligned with their chronological age. Their brains have been so sidetracked by the effects of their symptoms, and in the case of fear of harm, in the temperature dysregulation, that they just haven't been able to develop many of the age appropriate skills along the way. So it's probably safe to imagine that the child or teen is not, nor should they be expected to be, at age appropriate skill levels. This changes the question fundamentally from do we hold them to age appropriate standards to a more useful one. What standards are they already capable of, and how can we help them build from there? This is a kinder, gentler, and more empathetic approach than attempting to hold kids to standards set by children who don't have their illness. Psychologists call this process scaffolding, and it becomes a central piece of the treatment process. We start from what the child is able to do, remembering that just because we're able to do something once or twice doesn't mean it's a mastered skill that can be employed every time. Then we establish limits and rules around that skill. We provide supportive structure until that skill has developed into a mastered skill. Then, when the child is ready, we move the target and its scaffolding, slowly addressing new skills in progression as they're developed and mastered. So, how do you get started? Well, start with baby steps. Setting basic rules and limits that can be stuck to and that the child is capable of mastering will be essential to success. They can follow these straightforward guidelines. Assign simple chores. Establish rules and limits around one behavior or circumstance. Review the rules during times of calm and stability. Make sure what's expected is understood. And add only one limit, rule, or expectation at a time after the previous one has been learned. While there may be impatience to solve everything all at once, over time, the problem areas can be addressed. Incremental change is hard to see as it's happening, but after 6 months or a year, the change will be evident and the growth will be amazing.